Okay, let's go ahead and start. We're going to continue our discussion on bones. We had stopped on the composition of bones, and today we're going to take a look at how we get a skeleton very early in life. Anybody have any questions on anything before we start? Okay. Into bone development. Now, we have a skeleton in place. We have a full skeleton in place probably 6 weeks after conception. So we are probably an inch long. We have a full skeleton made out of mostly hyaline cartilage, a little bit of membrane. The bones of the skull are membranes, but everything else is hyaline cartilage, and all the structures that are going to become our bones are in place. Now, starting about week 6, we start the process of ossification. Calcifying the bones and letting them form. Now, this process of ossification means bone making, is going to last for the next 23 years. We're not going to be done with this process of ossification to reach our adult stature until we're about 23 years old. Now, we'll have a lot of surges of growth spurts during puberty and stuff like that, but the actual ending of the full skeleton being formed takes place by about 23. Then we continue to remodel on a constant basis. We replace we tear down 2 or 3% of our spongy bone every week, and every 3 years or so we've replaced all of our spongy bone, and every 10 years we've replaced all of our compact bone. Plus, our bones will change their shape depending on the stresses that we apply to them. But what we start out with, when we are in utero, we're about 6 weeks old, 6 weeks after conception, so we're only about an inch in size. The process of laying down bone starts. Now, most of our bones are hyaline cartilage, and these hyaline cartilage bones, it's just like the end of your nose. They're flexible, but they're the model for the rest of our bones. And so we use this process known as endochondral ossification. Chondral means cartilage. And so we replace the hyaline cartilage with bone. And this takes, again, this is the one that takes 23 years essentially to complete. Now, most of our skeleton is hyaline cartilage at this point. The rest of it, the bones of the skull and the clavicle, are going to be membranes, and they're going to be ossified also. But most of what happens is through a process known as endochondral ossification. I'm not going to go through all the various steps in this to explain how it starts, but somewhere around week 6 or so after conception, we start laying down in the long bones. We start putting down what's known as a primary ossification center. The primary ossification center is where we start. We're going to build spongy bone, and then we're going to build compact bone. We're going to have osteoblasts building out the matrix. And this process is going to continue in our long bones. We form what's known as a bone collar, a ring around the middle of like our femur, one of the shafts there. And as I said, we lay down spongy bone, then we develop compact bone, then we start moving to the ends of the long bones, and we have secondary ossification centers in the areas where the epiphyses are going to be. In fact, this is the beginning of the epiphyseal plates, and we will grow our bones from the epiphyseal plates. The shaft will will form, and then will continue to grow at the epiphyseal plates. And this is where our cartilage stays till we're about 23 years old, because the hyaline cartilage continues to grow and replace and be converted to bone. But somewhere along the line, you know, when we have fully ossified our bones, except for the epiphyseal plates, that's the only area left where we have cartilage, but that's where our growth takes place. So our bones are going to grow from the ends. And you can see the steps there. We create the bone collar. That's the primary ossification center. Then we have the secondary ossification center in the epiphyses. Everything else closes up except for the epiphyses, and we continue to grow there. And then they shut down. They're the last thing to shut down at 23, thereabouts. And this is what we look like. Here we are at 12 weeks after conception. We're about 3 inches long, if that. Now this looks like there's missing tissue, but it's not, because soft tissue doesn't show up on X-ray. We don't see the soft tissue. It's there. The soft tissue is where those gaps are on the image. We can see where the bones have started. The bones started ossifying 6 weeks earlier. The membranes have been ossifying for 6 weeks. The membranes, the bones of the skull are formed. But where we see the gaps, like at the carpal bones of the wrist, or the bones of the pelvic girdle, for example, you can see the femur, but you don't see the head and neck of the femur, or the condyles and the epicondyles at its distal end. They're there. They're just not visible because soft tissue, cartilage, doesn't show up. Eventually, they will completely ossify. So, you know, but right now you're not seeing it. But this shows you what's happening. If we went back 6 weeks earlier, we wouldn't see anything. We'd see no bone at all, because we would all be cartilage and membrane. Now, again, if we look at the skull, you can see where the membranes are located here. This is probably 10 weeks here, because there's a little bit less development of the bone than there was on the other image. But what will happen is that we will lay down ossification centers in these membranes that are covering the brain. The frontal bone, the parietal bone, the occipital and temporal bone are all going to be formed from membranes. The clavicles, go figure. The clavicles are also going to be from membranes. Everything else is going to be hyaline cartilage. Now, this membrane it's connective tissue with a lot of collagen fibers in there, a lot of reticular fibers in there. It's covering the skull. It will be the framework for the bones of the skull, the frontal, the temporal, the parietal, and the occipital in here. And they will gradually they'll develop an ossification center, and it'll spread out, and it will lay down a layer of spongy bone and put a layer of compact bone on either side of it. That's what the bones of the skull look like. They're that diploid structure with, you know, compact, spongy, compact. So we see, you know, again, as I said, the ossification center forms, osteoblasts are created or developed. We lay down the matrix. We start laying down, building trabeculae. We then have spongy bone, and then we cover it with compact bone. That's the process. We see some of this still in place, usually at birth, with the anterior fontanelle, for example. The fontanelles, the soft spots, are membrane. They don't close right away. You know, they're a great advantage for the baby during childbirth because it gives the skull some flexibility. Plus, I mean, as it's coming out through the birth canal, plus the brain is going to continue to grow. If you've ever looked at a small child, they are disproportionate in size. Their head is bigger than the rest of their body because we have to account for the brain is growing and constantly growing. And so we accommodate for that. You know, the skull can expand because of these fontanelles, these membranes that are still there. They don't close completely until we reach our adult stature. So now after birth, after we're born, we'll still see bone growth going on and changes. The long bones will grow, as they say, longitudinally, meaning lengthwise. And this growth occurs at each end of the epiphyses. You have a growth plate at each end, and they will be generating cartilage, hyaline cartilage, which will then be converted into bone. And that process will continue and continue until the growth plates shut down at 23. Now, the only bones that will continue to grow throughout our lifetime are some of the facial bones. And no guarantees they will, but some facial bones will grow. Some people will have a nose that gets bigger and bigger over time, or their frontal bone will get larger, or maybe their mandible will enlarge. But it's a very slow process. And that doesn't happen to everybody. Some people look the same at 60 as they do at 20, for example. Okay. Now, the remodeling that takes place goes on our whole life, whereas growth is going to be lengthwise. The remodeling is going to be what we call appositional growth, growing from side to side. The bone will get bigger or or smaller depending on the load it has to carry. So our bones will grow and be remodeled and grow and remodeled all the time, depending on what we do. But we're not going to get any bigger. You know, bones aren't like muscle cells where we're limited to the cells that we had when we were born. We develop bone cells all the time to meet the needs. Okay. And essentially all of our long bone growth lengthwise is due to the epiphyseal plates. And this, you know, if you want to look at a very complicated diagram of what an epiphyseal plate looks like, feel free to look at this. But it is from the hyaline cartilage, the chondrocytes, that we end up getting our long bones. Now, moving on here. And as I said, now at 23, our epiphyseal plate is just about ready to shut down. In fact, it may already have shut down in some people, and that's perfectly fine. The growth plates are visible on X-ray as a dark line because it's all hyaline cartilage. The proof that we have hyaline cartilage there is that you can see the growth areas. It looks like the bone is separated, but the bone isn't. It's a dark line because soft tissue doesn't show up on X-ray. Once that plate closes, it becomes what's known as the epiphyseal line. And that's a visible white line on X-ray. And we see, do we have a picture? Well, you've seen the picture of it in the lab, I guess. So, okay. So we get this white line across here. It's the scar. It's the residue from the epiphyseal plate. No more growth at that spot. So, and what controls all this? Well, we haven't talked a lot about hormones, but we will in AP2. We'll talk a lot about hormones. The whole first chapter, the whole first unit in AP2 is all about hormones. The hormone that drives our growth is cleverly called growth hormone. And that will stimulate the epiphyseal plate to continue to allow us to grow. But to do this, we have to have energy. So we have to use thyroid hormone. Thyroid hormone from our thyroid gland in our neck stimulates metabolic activity. It raises our energy level. when we go through puberty, we have greater energy demands because we are having growth spurts. At puberty, we see the release of large quantities of the sex hormones, testosterone and estrogen, and they are going to stimulate the growth plates. In fact, testosterone and estrogen stimulate the growth plates. They stimulate osteoblasts, the bone building activity, so rapidly that the growth plate can't keep up. And so we have osteoblasts that are growing at the ends of the long bones. We have this spurt, over 3 months or a year, we'll see the dramatic change in body size simply because of the growth spurt. The osteoblast, the growth plates are working as fast as they can, but because of the presence of these sex hormones, plain ordinary osteoblasts are developing at the same location and are just sort of blasting past the growth plate. Now, what will eventually happen is that as the sex hormone levels continue to rise to stimulate the secondary sex characteristics in the body, they will eventually shut down the growth plate. In the female, the estrogen stimulates so much osteoblast activity that yes, they get their growth spurt earlier in puberty, but they have so much estrogen coming out, it shuts down the growth plate. So they've had their rapid growth, but then they shut down the epiphyseal plate. In males, testosterone will stimulate the growth spurts, but it will have a slower effect, if you will. So that the average male stature is greater than the average female stature because males release their testosterone at a lower, quantity or whatever, or it takes longer for the growth plates in males to shut down. So males end up having several growth spurts and before they shut down. And that's the only reason why there is a typical difference in body stature. It has to do with the effect of the hormones on the growth plate. So as I said here, estrogens cause the growth plates to close faster than the testosterone does. Now, the whole idea of the onset of puberty is caused by the release of androgens. Androgens are sort of non-specific sex hormones released by the adrenal glands. They probably trigger puberty. Now, androgens are essentially testosterone. Everybody has testosterone from their androgens, but the female ovary converts these androgens into estrogen. So you have this part of the adrenal gland, and we'll talk a lot about this in AP2, but the adrenal gland releases these androgens, these hormones. We get the rapid growth. We get the androgens are converted to estrogen in the female. You get the rapid growth spurt, but there's so much estrogen available and the epiphyseal plates are so sensitive to it that they shut down earlier than do the growth plates in the male. Testosterone has a longer lasting effect. Now, the other thing about estrogen is that they continue to stimulate osteoblast activity, which is great. You need osteoblasts because you're going to keep remodeling your skeleton your whole life. But when the female goes through menopause and her ovaries shut down, then the amount of estrogen she has is significantly limited. All she has left are the androgens coming off the adrenal glands. And so she doesn't build up her bone as fast as she did before. In fact, what will happen is that in many older females, in many postmenopausal females, you're going to see that bone buildup is slower than bone breakdown. That's when you have osteoporosis. So anyway, okay. What else do we need to make bones work? We have to have insulin. And we all thought insulin was nothing but regulating sugar levels. Well, it does, but it also stimulates osteoblast activity. Who knew? Glucocorticoids, the stress hormones, the hormones that you use to control, to help you deal with stress. Cortisol, for example, inhibit osteoclast activity, the bone breaking cells. So both insulin and cortisol are going to stimulate bone growth. The two hormones that regulate calcium levels are parathyroid hormone and calcitonin. They're antagonistic. Parathyroid hormone works when our blood calcium levels drop, and it tells us it dissolves some bone to get the calcium we need, because there's lots of things in our bodies we need calcium for, and the best reservoir for calcium is in our bones. So we dissolve our bones. So we use parathyroid hormone to bring our blood calcium back up. If our blood calcium gets too high, we use calcitonin to bring it down, and that stimulates bone growth. So these two hormones are going to work against each other to regulate our blood calcium levels. And we can't lay down bone without calcium. We can't, if we don't have calcium, we're not going to be able to build bone, but we need calcium for our muscles to contract. We need calcium for our heart to beat. We need calcium for all of our nerves to function properly. So it isn't like we, just need to stick it in our bones and forget about it. Okay. So when we do remodel, how much do we tear down? Well, we're always remodeling. We're always tearing down and building up our bone. 5% of our bone mass is recycled every week. And as I said, spongy bone gets replaced every 3 years. All of our compact bone is replaced every 10 years. So every 10 years, we have a brand new skeleton in place. And we are going to tear down and build up at the same time. Osteoblasts, the bone builders, work side by side with the osteoclasts. Now, the osteoclasts are large cells full of lysosomes, which will dissolve the bone and release the calcium. And they are simply going to slide across the surface of the bone. If you've ever seen one of those large road construction machines, it rides across the asphalt, tears up the asphalt, and leaves the bare subsurface behind to put a new layer of asphalt down. That's what lysosomes, what these osteoclasts do. They tear up the bone and they let us then rebuild it, because they work together with an osteoblast. Now, there's two things that control remodeling: hormones and stress. Mechanical stress, not the other kind of stress. Mechanical stresses, like lifting weights or something like that. That's a mechanical stress, or adding more physical activity in your life. Hormonal controls and mechanical stress are the two ways that we control remodeling. Of course, we are going to base our remodeling a lot on our genetic makeup. What kind of bone traits did we inherit from our parents? What kind of body stature did our parents have, or maybe our grandparents, or crazy Uncle Fred 3 generations removed? Those are the physical traits we're likely to inherit. There's always going to be an anomaly that's going to show up there. We'll talk about the anomalies, but generally, our genetics plays a big role in what our skeleton's going to look like. So hormonally, first of all, we got to control calcium. So we have to use parathyroid hormone and calcitonin. We got to have lots of calcium. We got to have calcium for our bones. We have to have it for our teeth. muscle contractions, nerve impulses, coagulation of our blood when we bleed. Got to have calcium for that. We use calcium during when an egg cell is fertilized by a sperm cell. The egg cell will inject calcium into the sperm, so the sperm cell will drop its tail and drop its mitochondria so it can inject its nucleus into the egg. So strange places where we find these needs for calcium. We have most of our calcium in our bone, but to maintain our calcium levels, we're going to have vitamin D. Vitamin D allows us to get calcium out of in our diet. So, okay, back to the hormones. Calcitonin. In our thyroid gland, the thyroid gland sits here in our neck. Let's see if I have a. Oh, here we go. This is a thyroid gland. Let me let everybody see the thyroid gland here. This is the thyroid gland. It sits in your neck right about here. And it's about this size, maybe just a little bit bigger than the model, but this is pretty close. And the thyroid gland, first of all, its primary role is to produce thyroid hormone. It makes thyroid hormone for us, which controls all of our metabolic activity. You've heard of people that are, that are hyperthyroid or hypothyroid. Their thyroid's overactive, things like that. Thyroid releases thyroid hormone, which tells all of our cells to burn glucose, essentially to burn sugar. Now, in addition to that, we produce calcitonin. Now, there are cells called the parafollicular cells. You'll learn all about those in AP2. They produce calcitonin, and it is a classic negative feedback loop. If calcium levels drop, if the calcium levels get too high, calcium levels become elevated in our blood, the thyroid gland, the parafollicular cells in the thyroid gland will detect those high levels of calcium and will stimulate osteoblast activity to lay down that calcium into bone. But I'll tell you that we very rarely ever have normally have excessive calcium levels in our bodies. We are usually going to be, slightly hypocalcemic, meaning we're usually a little bit behind the curve on having enough calcium all the time. So calcitonin doesn't get to play very much. It only comes in on those rare occasions if we have excessive calcium. So it is not the #1 regulator of calcium. The important hormone is parathyroid hormone. Parathyroid hormone gets released from the parathyroid glands. Now, the parathyroid glands are on the posterior surface of the thyroid gland. So that would be show you here. Okay, this is the thyroid gland right here. You're looking at the anterior surface. If I flip it around, there will be 4 locations, 1, 2, 3, and 4 on the back side of the thyroid gland. That's where the parathyroid glands are located. Parathyroid glands are about the size and the shape of a raisin. There are 4 of them. They produce parathyroid hormone. If calcium levels drop, they're going to do 3 things. They're actually 4. They're going to inhibit osteoblasts, no more bone building. They're going to stimulate osteoclasts to break down bone to release calcium. They're going to tell the kidneys to not release calcium in our urine. We're not going to pee away any calcium. And it's going to tell our small intestine to recover calcium from our diet. So these four things are going to work in a classic negative feedback approach to say, hey, we need more calcium. Let's go ahead and get it. Let's break down bone and recover it from our diet and not pee it away. So 3 different approaches here to bring our calcium back up to normal. Now, this is the negative feedback loop for calcitonin. It's pretty straightforward. It's pretty simple. If blood calcium goes up, we release calcitonin. It inhibits the osteoclasts and stimulates the osteoblasts. Remember, the osteoclasts are the bone breakers, osteoblasts are the bone builders. So we stop breaking down bone because we've already got excessive calcium, and we lay down new bone. Don't use it very often because it's unusual for us to be in a position of having excess calcium. Now there's the parathyroid gland. Parathyroid gland, again, there are 4 of them on the back side, on the posterior surface of the thyroid gland. They're a separate gland all their own. They release parathyroid hormone. And as I said, they will stimulate osteoclast activity to break down bone. They will inhibit osteoblasts so we don't build up any more bone. We will tell the small intestine to absorb more calcium, and we will tell the kidneys to stop peeing away calcium. So we have 3 different things that we can do here. And this is the flow chart for parathyroid hormone. And while I'm not big in these large flow charts, you can see this one actually works pretty well because our parathyroid, our blood calcium levels are low. Parathyroid hormone gets released. On the left-hand side, it tells the osteoblasts to stop doing what they're doing, stop building bone. And it tells the osteoclast to start breaking down bone, which takes us to the bottom and gives us more calcium. In the middle, it tells us to make more calcitriol. Calcitriol is essentially the activated version of vitamin D. So the vitamin D that we're generating in our skin through ultraviolet radiation is not activated, but our liver and kidneys can activate it. And then with activated vitamin D, we can absorb calcium in our gut, in the small intestine. And then the third thing is really straightforward, tells the kidneys not to excrete calcium so we don't pee it away. Calcium is peculiar. We can be very easily slide into a hypocalcemic state, meaning low calcium, or a hypercalcemic state, meaning high calcium, very easily because it's just tiny amounts of calcium in here. If nothing else, if you continue to if you have a patient that takes in high levels of calcium on a daily basis, they're likely going to develop a kidney stone or kidney stones, because kidney stones are called renal calculi based on calcium. I used to work with a woman in a previous life, and she had this obsession for fruit-flavored Tums, the chewable Tums. Tums are nothing but calcium carbonate and some sort of fruit flavor. Tastes sort of like eating chalk, you know. I mean, it's not something that I would say, hey, let's have a snack, you know. She would go through a jumbo bottle of these every day. She had this mineral deficit where she called pica, and she would, you know, satisfy this craving by eating these Tums. Well, she'd go through a whole bottle a day, and she was always complaining, saying that she was always trying to pass a kidney stone. She never made the connection that this calcium loading was causing a health issue. A lot of people, and I point this out not to make fun of her, but because lots of people don't see over-the-counter treatments as medicine. So take all the calcium Tums you want because it's not going to hurt you. Take all the vitamins you want because they're not going to hurt you. Well, they do. At the very least, you get kidney stones. Now, if a person has low levels of blood calcium, because of its role in the nervous system, we become hyper-excitable. We become overstimulated, and our nervous system allows us to respond to stimulus. In a hypocalcemic state, we are overly sensitive to sounds and noise and temperature and pressure and touch and all this other stuff. And it doesn't end well. The same thing happens if we are hypercalcemic. If we have excessive calcium, we overload our nervous system, we become non-responsive. And that doesn't end well either. If nothing else, lots of calcium in our diet leads to kidney stones. So, and if you've never had one, ask someone that has, and ask how painful they are, because we're talking about a hunk of calcium, a salt that has formed, that's about the size of a nickel and has very sharp edges all sticking around, coming through your kidney, down through your ureter, into your bladder, and out through your urethra. So it's like trying to pee out razor blades, is how people have described it. So, okay, on that cheery note, other hormones, leptin. Leptin is a hormone released by our adipose tissue. Normally it's involved with dietary activities, but it also may have a role, because we're not certain, in inhibiting osteoblasts. So does serotonin. Serotonin is a mood stabilizer hormone that makes, in the right levels, we feel good if we have serotonin. Hey, I feel good today, so my serotonin levels must be up. It's definitely a mood stabilizing hormone. That can also interfere with osteoblast activity, possibly. So we don't operate in an isolated nature. Everything is, all these hormones it's all interrelated. Okay, so what about stress? Mechanical stress. So if you're going to become an Olympic weightlifter, you want to start lifting weights. You want to be able to go to the next Olympics, wherever it is, and be able to lift 2,000 pounds over your head and hold it up there so you can get a gold medal. Whatever you have to do to get a medal in weightlifting. So you exercise and exercise, you lift weights and you work out and you eat right and you eat lots of protein, and your muscles get larger. The muscle cells become enlarged and they're stronger, and they're pulling on the bones. Well, the bones are then going to respond to those stresses by getting larger also. The bones will respond to the stresses placed on them. We call this Wolff's Law. And this is the only law that you have to remember from AP1. It's Wolff's Law. Bones grow or remodel in response to the demands placed on them. It works either way. The more stress you place on a bone, the stronger it's going to get. The more weight you're lifting or pushing against, or the more you're exercising your muscles, the stronger your muscles are getting, or the more weight you're trying to lift, the bones are going to get stronger to correspond to the stronger muscles. If you don't exercise, if you don't lift weights, you don't have to lift weights, but if you don't exercise and don't stress your muscles to keep them healthy, then your muscles are going to shrink. You're not going to lose cells, but your muscles will shrink and the bones will shrink to match the muscles. So whatever our body does, whether we are exercising or not exercising, our bones and our muscles are going to reflect that. So Wolff's Law says that bones will always remodel to meet the demand, whichever way the demand is. And so our particularly in our long bones, the shaft of the long bone will become very thick where the greatest stresses are applied. It will also become very thick at the points of attachment of the muscles, wherever the muscles attach, like maybe the deltoid tuberosity or maybe the radial tuberosity, for example. The bony area there is going to get thicker as you have a larger attachment taking place. We see this also with our dominant hand. Most of us have a dominant left or right hand. Some people are ambidextrous and have equivalent dominance. But if you're right-handed or left-handed, your humerus is going to be larger on the right side than the left side, or vice versa. Because you do more things with your dominant hand. You're going to have your spongy bone will get larger. You'll have more trabeculae in there to deal with the stresses of motion. The compact bone will be thicker. You will have points of attachment will be stronger on the dominant side because we use it more. Am I gonna, I'm right-handed, so am I gonna use my right hand to clean the board, or am I gonna use my left hand and clean the board? Well, I use my right hand because I'm right-hand dominant. So the more activity we place on the dominant side, the stronger the muscle, the stronger the bone gets, the more places for attachments for the muscles to be there. The less we do, the smoother the bone will get. The bone will become less marked, less strong. It will meet the demands of whatever you have. A person who is, let me get back. A person who is sick, a person who has been in a body cast for 6 months, will see their bones change because they haven't had a lot of activity going on with their muscles. A person in space, an astronaut on the space station, there's one up there right now that has been there over a year. And without the forces of gravity pulling on his body, his muscles are shrinking in size. His bones are shrinking in size. His bones are getting less dense and weaker to the point that they could snap if he were to, when his spacecraft lands, when he's brought back to Earth, if he were to try and stand up and run, because his bones wouldn't be able to support his weight. Now he'll recover that fairly quickly, but he's had no gravity pulling on him. Gravity is, gravity's not our friend. We know that. It pulls on us all the time. In space, all they can do is exercise with resistance equipment. And that's just not, they can't do that for 24 hours a day. So, okay, now. So this remodeling will take place all up and down the shaft of the bone. The bone won't grow in length, but it will get thicker or thinner. The astronauts in the space station, if they're there for any length of time, their bones are going to get thinner because the stresses on them are much less. A weightlifter is going to be just the opposite. A weightlifter, the bones are going to get thicker because the muscles are stronger. So having said all that, let's talk about breaking bones. Many of us have broken bones, and usually when a bone's broken, you don't ever remember the actual event. You just discover after the pain subsides a little bit that, oh, I can't move my finger, or I can't move my hand, or my arm because it's broken. When we're younger, to some extent, most of our breaks come from some sort of trauma. We do things that in hindsight we probably shouldn't do. Here, hold my beer, watch this. That kind of stuff happens. Or we engage in contact sports and we break things. You know, they're all usually, you know, nobody plans to go break their bone, but it happens. It's some sort of trauma, accidental trauma. And it takes a lot of force it actually takes a lot of force to break a bone. Bones are very strong. We survive all sorts of things that don't break our bones. Then when we do break something, it seems this awkward arrangement where you have the right confluence of pressure and stress and torsion to make the bone break. However, when we get older, bones break a whole lot easier. Bones have thinned out. Elderly people don't exercise, don't always have the opportunity to exercise, or, you know, for a variety of reasons. And so their bones are weaker, and simple things break their bones. Some people, they trip. They trip on a rug, they trip on a stair, they fall down, they put their hand down, they end up breaking bones in their wrist because of the bones are weak. Sometimes bones just break while they're standing there. Sometimes somebody sneezes or coughs really hard and breaks a bone. It can happen. You know, so lots of things can cause fractures. You know, it can be from, you know, overloading the strength of the bone. It could be because the bone just is getting weaker. Now, funny thing about bones, though, is that bones are going to heal themselves no matter what we do. We don't have to do anything to a bone, and it will heal itself. However, it may not heal itself properly, but it will still heal on its own. The bone will start the process of healing right after the fracture takes place. And is it lined up right? That's about all that we can do, all we can do to make the bone repair itself, to help the bone repair, is to line up the fracture. So fractures come in a couple different classifications. We have what's known as a displaced or non-displaced fracture. Is the bone end lined up on either side? You know, is it complete? Is it intact? Or are they displaced? Or is it out of alignment? Is the broken bone broken all the way through, or is it a partial break? You know, so is it complete or incomplete? Excuse me. Is the skin penetrated? Is it an open fracture, a compound fracture where you've got bone sticking out through the skin, or is it closed? Is the skin intact? You know, so displaced or non-displaced, complete or incomplete, open or closed. These are the three big categories that you encounter with fractures. So open and displaced. There at the top on the left-hand side, we have a broken humerus, and the humerus is sticking through the skin. It's probably quite painful and probably messy. Green stick fractures, incomplete break. Skin's usually not broken. We call it green stick because it's like trying to break a stick on a tree that's still green. It won't snap all the way through. It'll only snap on one side. And so, you know, you have a partial break. The kids are great for these kind of green stick fractures. You know, they break something, but it's not a complete break. So it takes a lot to you know, have a complete fracture in a young child. Comminuted fracture, the bone breaks and goes to pieces. You can see it there. Linear fractures, probably the simplest type to treat. The fracture runs the length of the bone. Many times when you have patients that break their fingers, it's a linear fracture in their phalanges. You know, usually like in this first digit here in the fingers, or maybe a first and second, but it tends to run up in here. There's not a lot you have to do. You know, this is where you see people with a splint on one finger and it's taped to the finger next to it. That's usually a linear fracture. On the bottom left, we have a transverse fracture where the bone's broken across, but it's not out of alignment. That's easy to treat too. An oblique fracture, also not out of alignment. A spiral fracture, very common sports injuries. You put your foot down in contact sports, you place your foot down and you turn your body and everything turns except your foot and the bone twists. And this doesn't have to be, it can be anything. You can be walking and make a turn and suddenly, for whatever bizarre coincidence or occurrence, your bone snaps. Usually doesn't. It usually doesn't happen that way. Now, older people may experience that. Usually, if we see a spiral fracture in adolescents or young adults, it's because of some sort of contact sports injury. Here we see a Cole's fracture where we're looking at the end of the bone has snapped off right there, and the other part of the bone is jammed into it. And then we have what's known as a pot fracture, where we have fractures on both sides, like at the end of the ankle there. We see the fibula is broken. We also see the tendon is torn on the other side. So this might be the worst fracture ever seen. This is a floor gymnast. The Olympics, I guess it's last year. She's approaching the mat to go do her floor routine. And look at her legs. Look at the where the tibia is located. Your legs aren't supposed to bend back like that. So she snapped both tibias and probably both fibulas there when she, for whatever reason, the way she hit the mat, when she came down on the mat to start her routine, her legs snapped, both of them at the same time. And notice how they're definitely displaced out of position. Fortunately for her, they didn't rip through the skin, but it is excruciatingly painful. I mean, you can see the expression on her face. So, you know, who would expect that to happen when you're doing something you've done 1,000 times before and suddenly they snap? This was a sports injury on ESPN about 40 years ago. I dug it up off the internet. Note where I highlighted the area. What you're seeing is the leg and the foot being bent in 3 different directions, and it snapped the femur. And they said you could actually hear the snap on TV because it was so loud. So, and now there's a bone that takes a lot of effort to break. You know, you just don't break your femur because it's the largest and strongest bone in our body. But, you know, when your leg is bent in 3 different directions, things have to give somewhere. Okay. Stress fractures, common fracture at the hip. When someone breaks their hip, they usually are breaking the neck of the femur. Now, this is an MRI, and this doesn't show, you know, this is showing the surface of the bone. It's not like an X-ray that shows where you can actually see the presence of the calcium in the bone. But you see a fracture over there on the right hip, and you know, at the neck of the femur is where this always occurs, because osteoporosis will attack the neck of the femur and the head of the femur, because underneath the outer covering of compact bone is nothing but spongy bone, and that's what osteoporosis likes to go after, is the spongy bone. And so the bone had nothing but a shell, an outer shell of compact bone with nothing underneath it. And so whatever happened here, they sneezed, they coughed, they tripped, they were standing still, and their femur snapped. The femur on the left, let's see, we're looking at this is backwards. So yes, this is the left femur over here is intact. Now, we don't know from an MRI how much calcium is present, but an X-ray will show that. An X-ray, let me, I thought I had an X-ray there. Let me go back. Okay. The X-ray would show a white area wherever there's lots of calcium. Now this is, all we're seeing is the surface of the bone here. But the X-ray, if there's lots of calcium present in the bone, it would show, it would reflect and be white. If it's a dark shadow, then it means there's no calcium present. And I would hazard a guess that if we could see the X-ray of this, not just the MRI, we would see the areas where there were no bone present. Okay. To treat a fracture, we have to reduce it, meaning we have to line it up with the bone. When the bone is snapped, you have to line the two ends together. Now, in many cases, you don't have to do anything. If you break your finger, it usually is going to be a fracture that you don't do anything to. Maybe you want to tape it together, maybe not. A closed reduction means you just line it up, you manipulate the two ends without having to have any kind of surgical intervention. An open reduction means you have to have surgery to put the bone ends back together and maybe put some screws and plates or pins in there to line it up, particularly if there's lots of bits and pieces present. You generally have to immobilize the bone afterwards with a cast. In some severe cases, you have to apply constant traction to get the bone to heal, to keep it lined up. Traction and immobilization have come a long, long way in the past 100 years, where now casts are fiberglass, where they used to be plaster, or even before that, they would have boards embedded in the plaster around like a leg or something, which probably was doing more harm than good, but we didn't know any better 100 years ago. Now, fiberglass, very lightweight cast, walking, you've seen boots with walking casts. People have, our bodies recover very nicely. We don't have to do as much to help them recover. But if we do have to get involved to reduce the fracture with surgical intervention, it generally involves placing screws and pins and plates. Here we have a fracture of the tibia and the fibula. You can see the fibula is in pieces back here. And you have to line the bone up. Note the size of the fracture runs down along this area in here. And there's screws, stainless steel screws and large pins embedded in there. Those pins project out through the skin. They're held in place by another bracket. Lots of plates that you have to screw into the bone and have the bone grow over there to let it grow back. So, and this is what it looks like from the outside. There are the pins going through, holding the tibia together. And of course, that's what it looks like, when you're opening up the leg. Here we see reduction of the ulna and the radius. This is a very common type of procedure using plates and screws. You can see in the far side there, on the far right of the image, you can see the metal plates. They're stainless steel. The screws are stainless steel because they're non-reactive. And then the skin is held together. Those little round things are the staples holding the skin together. But look at the type of fracture in the first image over here. It takes a lot of effort to break the ulna and the radius, but they did, and they have to be put back together again. Now, this will recover. Your patient will recover and be fine after this, but there will be a certain amount of healing time going on here. Hip replacements. We talked about this in lab. This is what I was talking about here. Notice how dark that area is there, right around the trochanters of the femur. That shadowy area is the absence of spongy bone. There's no calcium present to absorb the to reflect the X-rays. And so you have to replace the head In many cases, a person who has fractured their hip is breaking the neck of the femur, and instead of trying to cast them and splint them and stabilize them that way, it's a whole lot easier to put a hip replacement in and send them home in 3 days, as opposed to keeping them immobilized in the hospital for months. So we've seen this before too. So again, knee replacements, we see lots of people with knee replacements. What we're doing there is taking off the worn out condyles of the tibia and the femur, replacing them with metal inserts, usually titanium or stainless steel, and putting in an artificial set of menisci. That's what this light gray pad is. The dark gray pad is the condyles, the medial and lateral condyles on the tibia. You can see them coming in. There they are right there. And the medial and lateral condyles of the femur are placed on there. And then there's your meniscus pad. The medial and lateral collateral ligaments that attach the femur to the fibula and the femur to the tibia are left in place. You can see there right here. This is looks like that is the medial collateral ligament. And then of course you have the patellar ligament that attaches the femur to the tibia. So everything is still held in place. All we've done is replace the ends where the wear and tear is located. So now when you have a fracture, healing takes about 6 or 8 weeks. And our bones get to work right away. The first thing that happens at the site of the injury is what's called a hematoma. That is where we bleed. A large clot forms because you've ripped apart blood vessels here at the site of the injury. So you have swelling, you have pain, you have redness. Pain comes from the bleeding into the site of the injury and putting pressure on pain receptors. The swelling is because you have extra fluid leaking into the interstitial spaces that don't usually go there. You have redness because you have increased blood flow. Now, that's all a good thing, ultimately, because you're bringing in red cells with more oxygen, you're bringing in glucose, you're bringing in white cells to fight infection. Now, eventually, within a few, maybe within 24 hours or so, the swelling, the redness, and the pain will go down. And then we'll start laying down an internal cast, a callus, over the site of the injury. The callus is made out of fibrocartilage, sort of the same material that you would see at the pubic symphysis, in the intervertebral disc. It's going to have, you're going to have osteogenic cells embedded in this cartilage. You're going to see collagen fibers shoot across to the other side to tie the two ends together. You're going to generate new blood vessels to replace the ones that were broken. And this callus will be in place here probably within 3 or 4 days. It's to hold the ends of the bone together. It's also the framework for the bony callus that will form next. It's our own internal splint. Now, and this is going to happen whether the bone ends are lined up properly or not. An individual who has a fracture and can immobilize their bone but didn't reduce it, their bone's going to heal in whatever position that bone's in. So, now, the bony callus will form after about a week. It will lay bone down across the side of the injury. And it will turn, it will have spongy bone with compact bone on top, and this will last for about 2 months. And then your bone's healed. And it is literally as good as new. And we didn't do anything. All we might have done was reduce the fracture by lining up the bone ends. But lots of individuals who don't seek medical care, your individuals that are homeless or can't afford medical care, the best they'll do is try to splint it and let it heal up, and it may heal off center or irregular, but it's still going to heal on its own. Okay, then the bone ultimately remodels to get it back to what it looked like before, or to some approximation of that if they didn't have it reduced. Of course, if it's a broken finger that was already lined up, you're not even going to notice it. It just depends. Now, with our bones, for everything to heal and work properly, we got to always have the proper amount of nutrition. We got to have carbs and proteins and lipids. We have to have vitamins and minerals. We have to have calcium in our diet. We have to have phosphorus in our diet. But we have to have this hormone called calcitriol. Now, calcitriol depends on the presence of vitamin D. Calcitriol is a hormone that allows us to absorb calcium in the small intestine. Now, we can't make calcitriol in the liver and the kidneys if we don't have vitamin D. Vitamin D comes to us courtesy of sunlight. When ultraviolet radiation strikes our skin makes vitamin D. We also get vitamin D in our diet. We also get vitamin D from vitamins. Vitamin D is not naturally, doesn't naturally occur in dairy products. It has been added to dairy products. So when you see milk, it says vitamin D enriched. Well, that's been saying that for probably 80 years because vitamin D has been added to milk for a long, long time. So vitamin D, which is known as cholecalciferol, becomes activated, which allows calcitriol to form, which allows us to absorb calcium in the gut. So, and we see here, the kidneys convert vitamin D into calcitriol. That's the activated version of vitamin D. Or the liver converts vitamin D into calcidiol, which then moves to the kidneys to be converted to calcitriol. In other words, we need calcitriol. We need the activated version of vitamin D to absorb calcium. So, okay. Now, problems, things that go wrong. This is the most interesting part of this, of the bone discussion. What can go wrong with our bones? Well, it turns out there's lots of things. There's three big diseases that affect our bones. Osteomalacia and rickets is the first one. Osteomalacia means weak bones. Rickets is the childhood version of osteomalacia. Osteoporosis and osteopenia. We've all heard of osteoporosis. We probably know people that are suffering from osteoporosis. Osteopenia is the precursor of osteopenia. It's starting to see a loss. Osteopenia means you're having a loss in bone density, but it's not. It doesn't necessarily mean you're going to get osteoporosis. Lots of older people have a loss of bone density over time. Are they going to get osteoporosis? Maybe, maybe not. The third one is called Paget's disease. This is where you have overproduction of immature bone cells. And so you see enlargement of facial bones or pelvic bones or arm or leg bones, but not at the same time. And so those are the three big diseases that can occur. The conditions that can occur are known as gigantism. Gigantism occurs when the pituitary gland starts secreting excessive levels of growth hormone early on in life and doesn't stop. And so your child, during childhood, your individual continues to grow rapidly. The epiphyseal plates just keep on growing. And it's not unusual for the individual to reach an adult stature of 8 feet. The pituitary gland did not shut down the growth hormone. Now, a similar condition that occurs in adulthood is called acromegaly. Now in acromegaly, the pituitary gland starts secreting growth hormone, but after the growth plates are closed. So we're at our adult stature. You know, you're 6 feet tall or whatever. And then you notice that your nose is getting bigger, or your mandible is getting bigger, or your fingers are enlarging. Acromegaly only affects the facial bones and the hands and the feet. It doesn't cause increased body stature. It causes almost a deformity of the facial bones here because it gets so large there. Now, gigantism will cause acromegaly. Your individuals that are experiencing gigantism will also have acromegaly. They'll also have the enlarged facial bones. It isn't just the long bones that grow, but a person with acromegaly doesn't necessarily have to have gigantism. They don't have to be a giant either. Third category is pituitary dwarfism. Your individual doesn't get above 4 feet tall. They didn't get enough growth hormone during childhood, during their growth periods. And so they are proportionately sized. Everything fits their body, but they're only about 4 feet tall. So no more than that. And it's simply because the pituitary gland decided not to release enough growth hormone. So osteomalacia. For whatever reason, the bones aren't getting the calcium and phosphorus they need. The bones are not strong enough to support weight. They are soft bones, they are weak bones. They hurt to put weight on them, to walk on them, and the bones can snap very easily. You could just be standing somewhere and one of your leg bones could snap. Rickets is what we're seeing here in the image on the right on the x-ray. Primary characteristic of this is bow-legged. The legs bow outward because they can't support the weight of the torso. See how the leg is bowing out here? The epiphyses on the long bones enlarge, but the shaft doesn't. They can't support the weight. This is caused by a lack of calcium or a lack of vitamin D, or both. Not very common in the US anymore. Other countries more so. But again, it's caused by a lack of vitamin D, a lack of calcium, or a combination of that. Osteoporosis. Probably the big one here, the one we see the most of. It's not one disease, it's multiple diseases. What happens is that the osteoclasts break down bone faster than osteoblasts are building it up. We dissolve the bone. Look at the top picture. Those are spongy bone with trabeculae there, healthy looking trabeculae. You know, trabeculae absorb shock in all different directions. That's why we have it at our hips and at our elbows, at our shoulders. Look at the bottom picture and you can see all this moth-eaten appearance as the osteoclasts are dissolving away bone. We tend to see this in the vertebrae and in our hip bones, particularly at the neck and head of the femur. So we are dissolving this bone. A person with severe osteoporosis usually only has the compact bone shell surrounding the head and neck of the femur or their vertebrae with nothing underneath there. And so fractures are very common. So what happens is that for whatever, osteoporosis starts after menopause in some women. The absence of estrogen is going to be the trigger for osteoporosis. Estrogen will stimulate the osteoblasts to grow and make new bone and inhibit osteoclast activity. But when menopause occurs, the ovaries shut down, and they were the primary source of estrogen. So we're not going to stimulate osteoblasts and inhibit osteoclasts. The only estrogen now available to the female is what's being converted from her androgens, and that's not enough to keep the osteoblasts ahead of the osteoclasts. So now not every postmenopausal female is going to develop osteoporosis. A female who has exercised regularly throughout her life, has had a good diet with lots of vitamin D and lots of calcium, may never develop osteoporosis. It just depends. And some are going to develop it right away. And it just depends there too. You may have a patient that did everything right and still gets osteoporosis, or has done everything wrong and they're 90 years old and they're not showing any signs of osteoporosis. It's just, sometimes it's fluky. What will happen though is your postmenopausal female that is experiencing osteoporosis will eventually see fractures, commonly on the vertebrae. The lower vertebrae will collapse because the spongy bone inside has been eaten away. Look at the picture on the bottom there. You see the normal trabeculae on the left, and what you have left on the right after osteoporosis has hit the spongy bone. The lower vertebrae collapse, the upper vertebrae sag down on top of the collapsed vertebrae. Your patient becomes stooped over and shrinks in stature. And it becomes very hard to move, very difficult to move because of this constant pain in the lower back, and the upper vertebrae have become splayed out in here. Also, you run the risk of fracturing the classic hip fracture at the neck of the femur, because the neck of the femur also looks like the osteoporosis picture on the right. Here we see, you can see the bulging on the picture on the left, the elderly female there, you can see the bulging of the vertebrae through her skin because the lower vertebrae have collapsed, have been crushed, and the upper vertebrae are now wedging outward. Here we see the classic fracture at the neck of the femur, right there highlighted in red. This is what osteoporosis does. It dissolves away the spongy bone underneath there, and the bone fractures. Again, and this is what I was talking about. Notice how on the picture on the far side there, the bone is, the femur is white. That shows that there's a lot of bone still intact there. On this x-ray, there's a lot of calcium present, but on this side, highlighted in the red circle, it's all dark. Osteoporosis has affected that side, that femur. And you can see, if you look carefully, the fracture, there's a fracture line right there. So, okay. So who gets osteoporosis? Well, a lot of women do. 70% by the age of 80, which means 30% don't. And between 60 and 70, it's about 30%. Your 80-year-old females are going to have a lot of wear and tear. They've lived a long time, and they've probably been taking care of themselves, but eventually their bones are going to start getting weaker and weaker. We all get arthritis over time. 95% of us develop osteoarthritis. That's the wear and tear arthritis. But as they age, the risk factors for osteoporosis gradually increase. But if your patient hasn't got it by the time they're at 80, it's not going to come roaring in at 81 and suddenly start dissolving all of her bone. It's going to be a gradual wear and tear. Now, what about men? Can men get osteoporosis? Because we don't seem to hear a lot about it, but yes, men can. Testosterone stimulates osteoblast activity, and it inhibits osteoclast activity. Men produce testosterone from the onset of puberty till the day they die. The numbers decrease over time. So it is possible for men to develop osteoporosis, but it is much less common. So now let's stop with osteopenia, and we will pick up with this on Tuesday. Anybody have any questions on anything?
I had a question.
Okay, then I'm going to get us out of here and hope you all have a good weekend.